I'm very happy to address this particular topic, and I was expecting to give this on Saturday, so there's some discussion of TPIAT, which may seem a little premature, but you'll get it. I have no disclosures, unfortunately. I didn't. The 3C designation comes from the American Diabetes Association, and it was adopted by the Centers for Disease Control, and it was adopted by the European Association for the Study of Diabetes. And it was published, it's been published many times. One time recently was in Diabetes Care. And this is the classic etiologic classification of diabetes. Type 1, as we all know, type 2, as we all know, and then type 3 means anything else, basically. It means secondary diabetes. That's not exactly true. Type 4 is gestational diabetes, and people don't use that term when they talk about gestational diabetes. But type 3 is any other form of secondary diabetes, which could be drug-induced diabetes, it could be diabetes due to endocrinopathies. But if you'll notice, there's type 3C, which is diabetes due to diseases of the exocrine pancreas, including acute and chronic pancreatitis, trauma, surgical resection, tumors, cystic fibrosis, hemochromatosis, fibrocalcific disease, etc. So pancreatogenic is a title that a lot of people understand, but 3C is the designation that the purists are using increasingly, and we think it's a good idea because it emphasizes the fact that there's more than just two types of diabetes. And that's actually a challenge for a lot of primary care practitioners as well as specialists to appreciate. Type 3C diabetes is common in chronic pancreatitis. If you just look at patients diagnosed with the disease, at least 20% have it. And as you follow those patients over the course of the next 15 or 20 years, 70% or more 85% of the patients will develop type 3C diabetes, and of those, more than half will ultimately require insulin therapy. 50% of the patients who undergo a Whipple operation have type 3C diabetes. Fewer than 10% of all diabetics in the US and Western Europe have type 3C, but 15 to 20% of all diabetics in Asia and the Indian subcontinent are said to have type 3C or pancreatogenic diabetes. The important thing is that type 3C diabetes carries the same risk of vascular and retinal disease as does type 1 and type 2 diabetes. So it is just as morbid as other forms of diabetes. In spite of that, many people don't appreciate or think or perceive of it as being a different type of diabetes. And I gave a talk a couple of years ago at the European gastroenterology meetings, and the GI guys came up to me afterwards and said, how are you going to convince the endocrinologists and the diabetes people to realize that this is different? We know it's different. How are you going to convince them to know it's different? And it's interesting how it has not received as much attention in the diabetes literature as in the gastroenterology literature. It is indeed a very different form of diabetes, and this table just sort of characterizes some of the principal differences. Clinically, ketoacidosis is very rare in type 3C diabetes. Hyperglycemia is relatively mild compared to type 1. But as you know, hypoglycemia is very common, and in fact, this is due, as we'll talk about, to the combination, the peculiar paradox of increased peripheral insulin sensitivity due to relatively low insulin levels and decreased hepatic insulin sensitivity, and we'll talk about the reasons for that. And this dichotomy of increased sensitivity and decreased sensitivity is what creates a condition that we know clinically as brittle diabetes. The patient is profoundly hyperglycemic. You bring the insulin bottle near the room, and the patient becomes hypoglycemic. And so it's an extraordinarily difficult form of diabetes to control because of this dichotomy in the action of insulin. We know that it has some specific hormonal signature. We know that pancreatogenic diabetes, due to all of the various forms, and I'll show you some, are characterized by lower levels of insulin, which makes it quite different than type 2 diabetes, low levels of glucagon, and very low levels of pancreatic polypeptide. It can occur at any age due to any one of a number of different causes. Well, what's the prevalence of type 3C diabetes? Very interesting study done by Philip Hart and his colleagues at the University of Gießen in central Germany. Very meticulously analyzed almost 2,000 diabetics that were referred to both inpatient and outpatient clinics and care at their academic medical center. They very compulsively analyzed the patients with regard to a history of pancreatic disease, the presence of anti-islet antibodies, abnormal pancreatic imaging, fecal elastase measurements of pancreatic exocrine function, and found, somewhat to their surprise, that fully 8% of their diabetic population was comprised of patients with type 3C or pancreatogenic diabetes. Further, they characterized those patients, and as you can see, 3/4 of the patients have chronic pancreatitis as the underlying cause of their pancreatogenic or type 3C diabetes. Well, this is a fairly dramatic and surprising number, since in North America, textbooks routinely will say that fewer than 1% of all the diabetics have pancreatogenic diabetes. When Hart and his colleagues looked at the patients that were in fact were appropriately labeled as type 3C diabetics, they found that half of those patients had been misdiagnosed, usually as type 2 diabetes, by their caregivers. So it was their conclusion that this condition is frequently underdiagnosed or misdiagnosed. In response to a need to understand this form of diabetes, particularly in association with chronic pancreatitis, Mike Rickles and his task force at the Pancreas Fest annual meeting over the course of a couple of years developed a number of inquiries, and a consensus conference was organized 2 years ago to address the prevalence, the diagnosis, the care of patients with pancreatogenic or type 3C diabetes caused by chronic pancreatitis. And this consensus conference also focused on how to differentiate type 3C diabetes from garden variety or more prevalent type 2 or type 1 diabetes. And they cited the criteria that Ewald and Bretzel and Philip Hart had used of identifying, documenting pancreatic exocrine insufficiency, either with a screening test such as fecal elastase C1 or more direct testing of pancreatic exocrine secretion, the finding of abnormal pancreatic imaging, usually in association with a history of pancreatic disease, and the absence of anti-beta cell antibodies. In addition, Rickles' consensus group also recommended that the deficiency of pancreatic polypeptide response to nutrients was an important marker for pancreatogenic diabetes. So what's this all about? How does this have anything to do with pancreatogenic diabetes? Well, as you probably know, pancreatic polypeptide is a 36 amino acid peptide. It's part of what's called the PP family of gastroenteropancreatic polypeptides. It is particularly interesting because it's prevalent almost exclusively in the ventral portion or the uncinate process and posterior head of the pancreas. These images are taken from a classic article by Lelio Orci, who studied this a number of years ago and showed that pancreatic polypeptide containing cells are present in this sort of mantle around the perimeter of the islet, which is composed, of course, primarily of beta cells. And in the head and uncinate process of the pancreas, there are very few glucagon-containing cells. In the body and tail of the pancreas, there are many more glucagon-containing cells and very, very few pancreatic polypeptide-containing cells. So PP is a marker of the ventral pancreas, whereas glucagon is more a marker of the dorsal pancreas. We know that because there's very few glucagonomas that occur in the head of the pancreas. How can this be? Why would PP be located there? Well, remember your endocrinology, that your embryology, the ventral pancreas begins as a separate organ, off of the forming hepatic bud that swings around behind the gut at about the 7th or 8th week of gestation, and then in most cases, but not all, is joined to or combines with the dorsal pancreas to form a single organ. But the point of it is that this remains, its origins is as a separate organ, and in fact, I don't know of any other way histologically to discriminate between ventral pancreas and dorsal pancreas other than this distribution of PP cells and glucagon cells in these two areas of the gland. Well, if that's true and PP is localized to the head of the gland, then it would imply that when I or any other surgeon takes out the head of the pancreas, that patient is going to be PP deficient. And sure enough, that's true. And this study was done a number of years ago by Neil Seymour and colleagues in Brooklyn, in which a number of patients who had undergone pancreatic resection, not for cancer, but for trauma, were studied, and these included patients that had had proximal pancreatectomies and distal pancreatectomies and age controls. And they were then underwent test meal studies to examine their PP status, and then underwent glucose clamp studies to look at their sensitivity to insulin. Not surprisingly, patients that had proximal pancreatectomy or Whipple operations were deficient in pancreatic polypeptide, had no response to a test meal, whereas distal pancreatectomy patients had a normal PP response to the test meal. When they were studied with the glucose clamp studies, it was found that the proximal pancreatic resection patients, or the PP deficient patients, had a lower level of insulin sensitivity, and this was restored to normal by an 8-hour infusion of intravenous pancreatic polypeptide. 1 month later, their levels of insulin sensitivity had fallen again. So this implied that the deficiency in PP had something to do with insulin action, and Neil went on in a number of studies using a rodent model to look at hepatic insulin receptor binding and showed that chronic pancreatitis was associated with fewer available insulin receptors on hepatocytes, and when animals with chronic pancreatitis were treated with pancreatic polypeptide, that deficient number of available insulin receptors was restored back to normal. So it implied that PP deficiency had something to do with the number of available insulin receptors, and that was a likely mechanism for this loss of hepatic insulin sensitivity. He went on to do a number of other studies, including looking at insulin receptor, hepatic insulin receptor protein, and insulin receptor gene expression, and showed that these were under the regulation of pancreatic polypeptide, and in PP deficient states, hepatic insulin receptor expression and production and availability on the hepatocyte membrane was deficient, and this could be corrected by PP administration. Well, it had been known for some time that pancreatic polypeptide deficiency was associated with severe chronic pancreatitis. Ian Taylor and John Walsh and others in Los Angeles had shown this a number of years before. And Chuck Brunicardi went on to do some studies in a group of patients with chronic pancreatitis, in which this same protocol of looking at a before, during, and after an intravenous infusion of pancreatic polypeptide was carried out in these patients. Patients who had severe chronic pancreatitis were remarkably deficient in pancreatic polypeptide in a test meal study, and when they were studied with before, during, and after an 8-hour PP infusion, it was found that the hepatic insulin sensitivity was deficient in the PP deficient patients. It was restored to normal by PP infusion and then reduced again a month later. When glucose tolerance was examined in these same patients and controls and pancreatitics were examined, in this figure, all of the open circles are patients who had diabetes or impaired glucose tolerance. The closed circles are all of the normal glucose tolerance patients. And this was a glucose tolerance test given before, 1 day after the 8-hour infusion of pancreatic polypeptide, and 1 month later. And what you see is that all of the patients with diabetes or impaired glucose tolerance had a lower mean plasma glucose level during the glucose tolerance test after the 8-hour infusion of pancreatic polypeptide. So this indicated that PP is truly a glucoregulatory hormone. It probably achieves its glucoregulatory effects through this regulatory process of controlling the availability of hepatic insulin receptors. This is not the only circumstance in which we see PP deficiency. Mike Rickles at the University of Pennsylvania has studied patients with both type 1 diabetes and after islet allotransplantation, and looked at the response of these patients after test meal, liquid test meal ingestion, and has shown that islet transplantations are also deficient in pancreatic polypeptide, as are long-standing type 1 diabetic patients. So the PP deficiency is also present in this condition as well. So if we just characterize what kind of conditions are associated with PP deficiency, we know that chronic pancreatitis is and is associated with hepatic insulin resistance. Pancreatic carcinoma has also been found to be associated with PP deficiency, and Cyril Simo in Murray Brennan's shop showed years ago that hepatic insulin resistance was characteristic of patients with pancreatic carcinoma. We know pancreatic resection, if it's a proximal resection or a total resection, is associated with PP deficiency and is also associated with hepatic insulin resistance. Cystic fibrosis is well known to be associated with PP deficiency and has also been studied with glucose clamp studies and has been shown to be associated with hepatic insulin resistance. And islet allotransplantation is also a PP deficient state and also has been shown to be associated with hepatic insulin resistance. So this consistent association of PP deficiency and hepatic insulin resistance makes it very attractive to think that PP is the common denominator for pancreatogenic or type 3C diabetes. Well, are there conditions associated with PP excess? And the answer is yes, pancreatic neuroendocrine tumors. In fact, almost all of the neuroendocrine tumors are associated with a secondary hypersecretion of pancreatic polypeptide. So it's a good marker for a neuroendocrine tumor of the pancreas. It's also present in nocidioblastosis, this diffuse hypertrophy and ectopic formation of islet tissue in the pancreas. We also know that PP excess is associated with type 2 diabetes, particularly type 2 diabetes associated with obesity. And these are studies that go back to studies done at the University of Michigan by Aaron Vinnick and his co-workers. And most interestingly, PP hypersecretion is characteristic of normal aging. It's the only hormone I know that as you get older, the levels go up in the bloodstream. And here's an example of a group of patients who were studied just with an oral glucose tolerance test. And here are young normal controls who have a modest rise in PP levels after oral glucose that then comes down again. Here are healthy patients, subjects over the age of 65, who start off with a much more elevated basal level of PP, rises more dramatically and then falls. And here are elderly patients with diabetes, type 2 diabetes. They have even a higher basal level, levels achieve even higher levels, and then fall. So there's an age-associated increase with PP levels and a type 2 diabetes-associated increase with PP, and that means that you can easily distinguish patients who are PP deficient from garden variety type 2 diabetes patients. Now, unfortunately, we can't use basal levels of PP to identify people who are deficient in PP. And this is just one figure that illustrates this, that basal levels of PP are almost indistinguishable between patients who are PP deficient and patients who have a normal response to the test meal. And this is somewhat assay dependent, but the problem is that even in larger clinical studies, it's very difficult to discriminate these two groups just on basal levels. So you have to use some sort of a provocative agent, and the question is what to use. Well, you can use glucose. You can look at PP levels in a glucose tolerance test, but there will be a very modest rise in PP in response to glucose. Glucose is a poor stimulant of PP. PP responds much more dramatically to fat and protein. So if you use a test meal, either a true meal or a standardized test meal, and the ones that have become most popular is just to give the patient an 8-ounce container of Boost or Ensure. That's a tremendous provocative stimulus for gut hormones in general and for pancreatic polypeptide release in particular. Now, the other issue about pancreatogenic or type 3 diabetes that's important to appreciate is the fact that there are a variety of other metabolic problems associated with this condition, not least of which is a deficiency in the fat dependent vitamins A, D, E, and K that are absorbed dependent upon the secretion of lipase. And this is just one of several studies that's been published. A series of 40 patients with chronic pancreatitis in which the pancreatic exocrine secretion was carefully measured. Some of these patients had been treated with pancreatic enzymes and some had not. And this was a study in which the levels of these fat-dependent vitamins were measured in these folks. And you can see that there's a general deficiency in A, D, E, and K in the total group. It's particularly predominant in the patients who are pancreatic insufficient without replacement, but it's also true in patients that are on pancreatic enzyme replacement. And this implies that being on pancreatic enzyme replacement doesn't necessarily imply being on adequate replacement. And Andres Gilrude, I'm sure, is going to speak to some of these problematic issues. It also means that the patients with deficiencies in bone metabolic density, osteopenia, and osteoporosis follow from the prevalence of vitamin D deficiency. So in the entire group, there was a high prevalence of these metabolic bone disturbances in these patients, and this was true even in patients who were receiving pancreatic enzyme replacement therapy. So therefore, if we, in the absence of any clinical studies and any clear evidence yet to have been published in the literature about methods of treating pancreatogenic diabetes, we would propose that there's some obvious concerns and attention to some of these details. So patients who are diagnosed with pancreatogenic diabetes or type 3C diabetes, it's important for caregivers to first look at lifestyle alterations, smoking cessation, alcohol abstinence, weight loss, exercise. All of those things have been reported to improve outcomes. And as a medical approach, the patients need to be started on pancreatic enzyme replacement because most patients with pancreatic exocrine insufficiency don't have classic symptoms of steatorrhea. Most physicians don't measure pancreatic exocrine secretion in their patients. If they ask the patients at all, they say, "Do you have loose stools?" The patient says no. They go on to the next section of questions, and that's it. So it's important to realize that most of these patients are manifest pancreatic exocrine insufficiency. And then a good choice for a starting medication in these patients is metformin. It's not a perfect choice. Metformin has a side effects profile which includes gastrointestinal effects, so it may not be tolerated by all patients with chronic pancreatitis because of the prevalence of GI symptoms. If the patients persist in having elevated hemoglobin A1C levels, probably a smart next move is to think about TZDs or alpha-glucosidase inhibitors as a way to avoid insulin secretagogues. If the patient's diabetes resists therapy, certainly basal insulin formulations can be added. If that's insufficient, intensive insulin therapy. If that's insufficient, then other adjunct agents can be added, like pramlintide and other agents. The point of it is that the recommendations are to try to avoid some of the compounds which may be problematic. In the consensus report from the Pancreas Fest meeting, it was pointed out that there are a number of issues which complicate the choice of therapeutic agents in pancreatogenic diabetes. One issue in particular is the potential use or possible use of incretin-based therapy because of the associated pancreatic abnormalities that have been reported or suspected with incretin-based therapy. It seems prudent to avoid using those drugs until we have better data, better safety studies, better long-term treatment studies to tell us whether those drugs are really truly safe in patients with pancreatogenic diabetes. So in summary, type 3C diabetes is a consequence of chronic pancreatitis or pancreatectomy or in fact of TPIAT. It is characterized by hepatic insulin resistance due to a loss of PP-mediated hepatic insulin receptor availability. It can be differentiated from type 2 diabetes by a deficiency in nutrient-stimulated PP. And there are special considerations which are needed both for glycemic control and for pancreatic enzyme replacement in all patients with type 3 diabetes. Thank you very much.